Good morning, everybody. I'm Dr. Linda Martin. I'm a thoracic surgeon at the University of Virginia and a co-chair of this meeting. I would like to welcome you to the first of two press briefings from the IASLC 2024 World Lung Conference. And this is from the Presidential Symposium that just took place. It is among our sessions as abstracts that are selected as the very highest rated throughout the meeting submissions. Before we get started, a couple of housekeeping items. Please hold all your questions until the end of the briefing. The briefing is being recorded and will be uploaded to the IASLC YouTube channel after the briefing concludes. We have a lot of ground to cover, so we'll get started. We're going to start with two presenters, and then they're going to be dismissed because they have other sessions to get to. The first talk is going to be from Dr. Tina Casconi. She is presenting NeoCOAST-2, Efficacy and Safety of Neoadjuvant Durvalumab plus Novel Anti-Cancer Agents with Chemotherapy and Adjuvant Durvalumab plus Novel Agents in Resectable Non-Small Cell Lung Cancer. Brief background about Dr. Casconi. She is a physician scientist and associate professor at the Department of Thoracic Head and Neck Medical Oncology at MD Anderson Cancer Center. She received her medical training and doctorate degrees from the University of Campania Luigi Vanvitelli.
Wonderful. I'm impressed.
In Naples, Italy. Dr. Casconi completed her postdoctoral studies at MD Anderson, where she studied the impact of anti-angiogenic therapy on the tumor microenvironment. She currently serves as a principal investigator on several clinical trials evaluating neoadjuvant and perioperative immunotherapy strategies for patients with operable non-small cell lung cancer, including NeoStar, NeoCOAST, NeoCOAST-2, and Checkmate 77T. Her research program is supported by multiple peer-reviewed grants and awards, including an NIH NCI MPI R01 grant. See if you can keep track of all that, and the Lung Spore Award, and a Mark Foundation Endeavor Award, the Lung Cancer Moonshot Program, and a Sabin Family Foundation Award. Thank you for your excellent presentation, Dr. Casconi.
Thank you very much, Dr. Martin. It's just such an incredible pleasure and honor to be here today, especially after this memorable plenary session today. So it is my pleasure to really present the initial efficacy and safety data of the NeoCOAST-2. This is a phase 2 open-label multi-arm platform study for patients with perioperative non-small cell lung cancer. A key eligibility criteria for this study: patients with stage 2A, 3B resectable non-small cell lung cancer based on the AJCC 8th edition, and EGFR and ALK type and ECOG performance status of 0 or 1 were randomized to 4 treatment arms. You can see that stratification was by baseline PD-L1 tumor proportion score, or TPS. Primary endpoints were PCR rate, safety, and tolerability, and key secondary endpoints were the MPR rate, EFS, and feasibility of surgery. Now, I want to point out that this study was not powered to make any direct statistical comparison between the arms. The primary intent was to look for preliminary efficacy signals by calculating the PCR rates. Today, we presented the preliminary efficacy and safety data from Arm 2, Arm 1, and Arm 4. So Arm 1 and Arm 2 consisted of neoadjuvant durvalumab plus platinum doublet chemotherapy with the addition of either oleclumab or monalizumab followed by surgery, and adjuvant durvalumab with either oleclumab or monalizumab. Arm 4 consisted of neoadjuvant Dato-DXd, a TROP2 directed antibody drug conjugate, plus durvalumab and single-agent platinum chemotherapy. So primary endpoint and secondary endpoint in the modified intention to treat population, a PCR was observed in 17.2%, 20%, 26.7%, and 34.1% of patients in arms 1, 2, and 4. And an MPR was seen in 45%, 43.3%, and 65.9% of patients in arms 1, 2, and 4. In an exploratory comparison with the MPR and PCR rates seen with the neoadjuvant durvalumab plus chemotherapy, which was evaluated in the phase 3 Aegean study, as you can see on the left, you can appreciate the highly promising activity of these new treatments in the NeoCOAST-2. Here you can see the waterfall plot representing pathological responses, specifically in Arm 4, the Dato-DXd arm, and the annotation bars are representing the PD-L1 expression, the stage, and histology breakdown. You can see that higher PCR rates were seen with higher PD-L1 expression cutoff, and specifically in this arm, there were no differences in terms of PCR rates between histologic subtypes, 30.8% PCR rate for adenocarcinoma histology, 35.7% PCR rate for squamous cell histology. In terms of safety, the Dato-DXd arm plus platinum chemotherapy, single-agent platinum chemotherapy in durvalumab had a very manageable safety profile. In comparison with the Aegean study, you can see that grade 3 and higher treatment-related adverse events only occurred in 80.5% of patients and in the neoadjuvant phase, and 7.4% of patients in this phase discontinued treatment due to adverse events. As far as the adverse events of special interest for Dato-DXd, you can appreciate on the right, those included oral mucositis, stomatitis, ocular surface events, mucosal inflammation that was non-oral, as well as ILD and pneumonitis. There were really no increased rates of these events in the Dato-DXd arm in the neoadjuvant phase, which was when we combined the agent with immunotherapy. So highly encouraging and promising. So in conclusion, in the perioperative non-small cell lung cancer setting, novel treatment combinations demonstrated promising pathological responses compared to historical benchmarks with the highest PCR and MPR rates seen with the Dato-DXd, durvalumab, and single-agent platinum therapy. This is the first global phase 2 study showing encouraging pathological response rate for the Dato-DXd TROP2 antibody drug conjugate in the neoadjuvant setting for patients with resectable non-small cell lung cancer. And very importantly, Dato-DXd in combination with durvalumab and single-agent platinum chemotherapy as a neoadjuvant treatment demonstrated a manageable safety profile in patients with resectable non-small cell lung cancer with similar rates of adverse events of special interest compared to historical monotherapy data. Thank you very much for your attention.
Are there any questions from the audience? Okay. I have a quick question. Dr. Pascotti, I don't know if you can answer this, but how was it to operate after Dato-DXd?
Yes, very important questions. Well, of course, we are gathering all the data. As you have seen, the neoadjuvant safety profiling is the one that has the longest, right, more mature follow-up. But you can see that in the post-surgical phase for the oleclumab and monalizumab, as well as the Dato-DXd, we really didn't appreciate any major safety events, at least not differently from what we have appreciated even in the phase 3 large studies. As I mentioned this morning, in the Dato-DXd, there was one patient that in the post-surgical period had an event of that for idiopathic pulmonary fibrosis. But as far as the surgical potential complications, these were very much in alignment with what we've seen so far.
And the death was someone who had pre-existing pulmonary fibrosis before they even started any therapy?
That is correct.
Okay. And what's next? You know, based on these results, what are the next steps? Are you going to choose certain arms and expand upon them, or what happens from here?
Yes, thank you for this question. It's probably the most important topic after NeoCOAST-2. I think this trial really provides us with an important platform to really make this decision moving forward. We're looking now with translational analysis really and biomarker based, especially what Dr. Garcino has shown today on how we want to combine the Dato-DXd with emerging science and how we will bring that forward in the larger setting. So stay tuned.
Dr. Cascone, we have a question from one of the reporters who's in the press briefing online. His name is Miles Stars. He's from the AACR's Cancer Discovery. He's asking, why was the data from Arm 3, volrustomig, not reported on?
Yeah, thank you, Miles, for the very important question. The data on the Volru will be reported at upcoming meetings. So we are performing more work. The trial with this arm is still ongoing, and so we will be presenting data when ready. Thank you for the question.
Okay, thank you so much. Our next presenter is going to be Dr. Marina Garasino from the University of Chicago. She's going to present results from the normalized membrane ratio of TROP2 by quantitative continuous scoring as predictive of clinical outcomes in TROPION-Lung01. Dr. Garasino is currently a professor of medicine within the Department of Medicine, Hematology Oncology at University of Chicago. Until February 2021, she was the chief of Thoracic Oncology Unit at Instituto Nazionale de Tumorai, Milano, Italy. As a head, she led the strategy for clinical and translational research in advanced and locally advanced non-small cell lung cancer, small cell lung cancer, mesothelioma, and thymic malignancies. Her main research interests have been mainly development of new drugs and therapeutical strategies and biomarkers. She has contributed over 200 peer-reviewed publications, including as first or last author in the New England Journal of Medicine, Lancet Oncology, Journal of Clinical Oncology, and Annals of Oncology. She has given several presentations at major international congresses, and she's going to present her paper from this morning. Thank you. While they're working on the technical issues, just to give a slight translation into layman's terms, this is looking at a new biomarker strategy for a drug for which we haven't had a good biomarker despite multiple other attempts.
Thank you. Thank you. So I will try to explain things in a very easy way. It was difficult also for me. So I think that to understand the biomarker, it is important to go back to the mechanism of action. And unlike other antibody-drug conjugates, so it's important to underline that this biomarker will apply to Dato-DXd and not to other TROP2 antibody-drug conjugates. You see that the drug must be bind to the membrane, then must be internalized in the cytoplasm, and in that way can release the cytotoxic payload and the cytotoxic effect. So the majority of the biomarkers that were developed before, they try to understand if the TROP2 expression in the membrane was predictive or prognostic of the activity of the TROP2 antibody-drug conjugate. In this concept, there is the concept to use also on not just the TROP2 on the membrane, but also the TROP2 that is expressed in the cytoplasm. And you know already that the Dato-DXd has demonstrated a statistical improvement in terms of progression-free survival, and tomorrow morning you will see also the presentation of Dr. Sands about the overall survival. And so it is really crucial to identify those patients who really benefit of this drug. So I think that this is really a breakthrough because it's the first biomarker done with digital pathology. And this is a very easy process, so don't be scared. First of all, you have to scan. I was scared as well, but we have at the University of Chicago is a lab of digital pathology, so maybe I was more easier for me. But you can see that first of all, you have to stain the tissue with the TROP2, which is an antibody. Then you have to scan the image with the scan. And there is an automatic process for which you are able to differentiate, first of all, the tumor from the non-tumor. And in each tumor cell, you are able to calculate the TROP2 intensity in the membrane and in the cytoplasm. In that way, this was possible to calculate a ratio, that is the ratio of the TROP2 in the membrane and the overall TROP2 in the membrane and in the cytoplasm, that allowed to create a positive or negative, also maybe this is not the right term, but we consider positive the TROP2 NMR less than 0.56 in 75% of tumor cells. Clearly, this is negative because this is a ratio and the denominator is higher compared to the membrane optical density. So this clearly was translated in the samples. There was a population that was available for the tissue samples for the QCS, the determination. But it's important to underline that the cutoff was optimized in a specific population, that is the population of patients with non-squamous and non-actionable genomic alterations in the tropion-LUNG01. So what is, in my opinion, interesting, as you can see on the right, I think that you are aware that the Dato-DXd apparently is more effective in the population of the non-squamous. And in fact, you can see that the proportion of patients who are NMR positive in their tumor is higher in the non-squamous compared to the squamous population. And again, if you look at the Kaplan-Meier curves, you observe that there is a prolonged progression-free survival in patients treated with Dato-DXd who are NMR positive compared to those in the red curves who are NMR negative. There is a double response rate in patients who are NMR positive compared to those who are NMR negative. And I think it's also important to underline that you can see that there is no effect in the population tested for NMR treated with docetaxel, suggesting that this can be really potentially a predictive biomarker and not a prognostic biomarker. We saw the same effect also in the population of non-squamous without actionable alterations. And again, you can see the same results, longer progression-free survival and a higher response rate in the population which is NMR positive. There are no safety signals that are important. The grade more than 3 are similar in the NMR positive and also in NMR negative. And so many trials in the future will incorporate this as a biomarker. In particular, there are a couple of trials that are using this as a biomarker from the beginning, and I think that this will be incorporated in multiple other trials that are exploring the activity of the Dato-DXd. So to summarize, I think that this is really the first TROP2 biomarker. And of note, I think that this is the first computational pathology biomarker that I recall, at least in lung cancer. And I think that this will open a new era of the biomarker discovery and the biomarker development in lung cancer. Thank you.
We'll take questions from the floor. Any questions?
I can pass the mic if you have a question.
Yes.
Hold on.
Thank you. I'm June Zhang from Houston Methodist Cancer Center. I have a question. So it's very, very interesting with those molecule data DXC. And I think from Dr. Cascon's presentation to your biomarker, I mean, that is just already very impressive, neoadjuvant with, PR of over 30% and MPR of 60%, perhaps like, it's just like by my calculation, 100% everybody is like, at least is MPR. So how do you see this marker in the neoadjuvant setting? Does it need that marker to select who you will enroll into the neoadjuvant trial?
I think that maybe also Dr. Cascone can comment after me, but I think that you have to think that these are very preliminary data, and this is a subgroup analysis of a large phase 3 trial. There is a lot of potential, and I truly believe that they will incorporate also in the neoadjuvant setting, because your question is super correct.
Precisely and eloquently. I think, yeah, let's remember this is absolutely highly encouraging results from a metastatic cohort, pre-treated cohort. Definitely there will be translational work in the neoadjuvant setting to understand how we can apply this biomarker for patient selection.
Any other questions?
Yeah, so one more from Carolyn Helwick from ASCO Post for Dr. Garacino. For TROP NMR testing, would this apply to other TROP2-directed antibody drug conjugates aside from Dato-DXd?
This is a clear answer, no, because the mechanism of action of Dato-DXd is different from other TROP2 antibody drug conjugates. There are antibody drug conjugates with a cleavable linker. There are antibody drug conjugates with a different linker. And so the internalization to the cytoplasm can differ, and also the mechanism of action. So this biomarker for the time being applies only to Dato-DXd.
Thank you. Any other questions for Dr. Garacino?
Yeah, I think that this is another very interesting question. I think that this will be the future of the research. And I think that also the optimization of the cutoff can be different in the early stages and the advanced stages. And so I think that this is just the beginning, hopefully, of a different story.
I have one or two follow-up questions that I think mirror some of the questions from the audience earlier. But first of all, the positive result is when there's a lower ratio. And just to be clear, it sounds like if there's more of this NMR in the cytoplasm, that you get more effect. Is that right? So it's just that if there's more of the normalized membrane ratio within the cell as opposed to on the surface of the cell is when you get the better effect.
Is correct.
Okay.
So you see that this is a ratio. So if you increase the cytoplasm optical density, clearly the ratio will go down and will be less than 0.56. Sometimes it's difficult to think in the opposite, positive less, but this is the ratio, and so this is why it is like this.
And then the other one is this fully supervised digital pathology. Does that mean pathologists are going to be out of work? What does that mean?
This is a politically not correct question. So, clearly the pathologists will be always on board of the process. But I think that what we understand, for example, in this particular case, is that the determination of the optical density is superior to the human eye. And so to calculate the optical density in the cytoplasm and in the membrane, also the best pathology in the world is not able to do the same calculation as a machine. So this does not mean that the pathologists will disappear. This means that they have better eyes, maybe.
The IHC slide you have from the previous, so it doesn't have to be a new sample?
No, so you need one slide.
Yep.
You have to stain for a TROP2, and then there will be the discussion, which is the best antibody for the TROP2 to test the TROP2, and AstraZeneca is partnering with Ventana for doing this. And when you scan, basically you put in the machine and you have the result. So this is to make it simple for the people. So you don't need the supercomputers. Yes.
Okay. Great. Should we move on to the next one? Any other questions? No? Thank you so much. Yes. Okay. Our next presentation is from Dr. Patrick Ford on perioperative versus neoadjuvant nivolumab for resectable non-small cell lung cancer patient-level data analysis of Checkmate 77T and Checkmate 816. And Dr. Ford is from the Bloomberg Kimmel Institute for Cancer Immunotherapy at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins University. He is a medical oncologist who treats patients with lung cancer, mesothelioma, and other thoracic cancers. He is co-director of the Division of Upper Air Digestive Malignancies in the Department of Oncology at Hopkins and directs the Multidisciplinary Thoracic Oncology Clinical Research Program. He's led the development of a translational research program focusing on the immuno-oncology of upper air digestive malignancies. Dr. Ford's research examines the role of immunotherapy for mesothelioma and lung cancer, and his investigator-initiated research forms the basis for several ongoing phase 3 trials. In 2022, his work over several years culminated in a publication of Checkmate 816 in the New England Journal of Medicine and led to the first approval of neoadjuvant chemoimmunotherapy for the treatment of surgically operable lung cancer. Dr. Ford will now present his data.
Thank you very much, Dr. Madden, and I'm very pleased to present these data again. These were two trials, Checkmate 816, which was a neoadjuvant-only trial, and Checkmate 77T, which was led by Dr. Casconi, who was here a few minutes ago. And we're looking at trying to compare the data from these trials using the individual patient level. So at present, neoadjuvant nivolumab plus chemotherapy is the only approved neoadjuvant-only immunotherapy regimen for resectable lung cancer. In Checkmate 816, the the event-free survival benefit was shown with a hazard ratio of 0.63 favoring neoadjuvant chemoimmunotherapy. The Checkmate 77T trial, which was published earlier this year, then built on the Checkmate 816 by adding post-operative immunotherapy. So not just pre-op, also post-operative therapy. And that trial also showed a significant event-free survival benefit versus placebo with a hazard ratio of 0.58. Reassuringly, the pathologic complete response rates across both of the trials with neoadjuvant therapy, very similar therapy, were quite similar in the 24 to 25% range. So a key question that comes up in clinic when we see patients is they get their neoadjuvant chemoimmunotherapy, they have their surgery, and they come back to clinic. Should they receive further adjuvant immunotherapy or not? So we conducted this exploratory analysis. The analysis population for this was patients from Checkmate 816 who had neoadjuvant chemoimmunotherapy and definitive surgery, and patients from 77T who had neoadjuvant chemoimmunotherapy followed by surgery and at least one dose of adjuvant nivolumab. The endpoint for this exploratory analysis is event-free survival landmarked from the time of surgery, and this is different to the primary endpoint of these trials, which was landmarked from the time of enrollment. Here we're cutting off after the patient has got the neoadjuvant portion and surgery. This is in place of a head-to-head trial. It takes many years to conduct a large randomized trial comparing these treatments. So this is an exploratory propensity score weighting methodology. Two different methodologies were used to try and reproduce a randomized trial by adjusting for clinically relevant baseline demographics and disease characteristics and reduce the confounding effect of these variables. The duration of follow-up was similar in both studies. These are the unweighted baseline characteristics, quite similar in both groups, apart from more Asian patients in the neoadjuvant group and slightly more patients who had an ECOG performance status of 1 or greater in the perioperative group. And after weighting was performed, the demographics were very similar. This is the primary analysis result from this study. Based on the parameters I described, the addition of adjuvant nivolumab after neoadjuvant chemoimmunotherapy in Checkmate 77T delivered an approximate 40% reduction in the risk of disease recurrence or death compared to neoadjuvant-only therapy using one weighting methodology. Using the other weighting methodology, a very similar result, hazard ratio 0.56. And in the unweighted analysis, there was also benefit for perioperative therapy. The question that came up after the presentation just now was patients who actually get to adjuvant therapy, they may be fitter, they may be healthier. So what happens if you include all patients from each study from the time of surgery? And that landmark analysis is in the subscript at the bottom here, but the hazard ratio there is 0.82, still trending towards perioperative therapy being better. We looked at various clinical subgroups who may be clinically relevant. Pathologic complete response was presented in Dr. Kisconi's presentation earlier as a key endpoint, which is emerging in lung cancer. Both groups appear, at least by hazard ratios, to derive benefit from perioperative therapy as opposed to neoadjuvant, but you can see the curves are very close together in the PCR group because these patients are doing really well from neoadjuvant therapy. Very few events are occurring, whereas in the non-PCR group, they don't do as well. And there does appear to be perhaps an incremental benefit for giving those patients further adjuvant therapy with a hazard ratio of 0.65. PD-L1 status is a very important biomarker in lung cancer. And here we see those patients who have PD-L1 negative tumors appear to derive significant benefit, I shouldn't say significant, this is exploratory, from perioperative therapy with a hazard ratio of 0.51. In the PD-L1 positive group, the concept, I think, at the moment in lung cancer is that neoadjuvant therapy is beneficial for these groups. And you see both of these groups are deriving benefit from the neoadjuvant treatment. Very hard to separate them yet in terms of adjuvant therapy or no adjuvant therapy. Again, clinical stage, very similar benefit across both groups for perioperative therapy. Safety was similar across both of these groups, whether you give neoadjuvant only or perioperative, at least in the immediate term after surgery. In particular, treatment-related adverse events were similar and surgery-related adverse events. So finally, in summary, we will not have a randomized control trial in the near future available to us. So this analysis is the only available comparison of perioperative pre and post therapy versus neoadjuvant only immunotherapy for patients with resectable lung cancer. It uses individual patient-level data from 2 randomized trials. It appears that perioperative therapy, at least in this analysis, delivers a 40% reduction in disease recurrence or death in those patients who get to the adjuvant portion. Similar benefit was seen regardless of baseline stage, with greater magnitude of benefit in those patients who had PD-L1 negative tumors or those patients who did not have a PCR at the time of surgery. And in general, the safety profile was manageable. Now that we have multiple approved or pending approval regimens in this setting, this could help inform our discussions with our patients and with clinicians in terms of whether to recommend further adjuvant therapy after neoadjuvant. But thank you very much, and happy to take any questions.
Dr. Ford, we have a question from ASCO Post to Dr. Ford. Do your findings validate the use of adjuvant checkpoint inhibitors for essentially all patients?
So one thing I didn't mention was, so when I talk about adjuvant here, I'm talking about post-neoadjuvant. There is a whole separate group of patients who go directly to surgery and get adjuvant therapy, and so I don't think that therapy is affected by this study. Prefacing it to that degree, I think what it does show, at least in exploratory fashion, is that there are patients who benefit from further immunotherapy after neoadjuvant chemoimmunotherapy. Now, whether all patients benefit, I think that's less likely. But patients are different, disease characteristics are different. So there were very likely some subgroups who derived benefit and some who did not. In this analysis, the 2 groups that stand out deriving benefit are those who have PD-L1 negative tumors, who do not derive as much benefit from neoadjuvant only. So that could be what we're seeing here, that those patients who don't get benefit or as much benefit from neoadjuvant need some further therapy. And also those patients who don't have a PCR, who are again a group who are not deriving as much benefit from the neoadjuvant therapy. So I think that would be my perspective. And as well, those are 2 groups where if you're in the clinic, you can they're at higher risk of relapse of disease. So you're not trying to push their relapse-free survival from 95 to 96%. You might be trying to improve it from 55% to 70%, which is a bigger increment. So I think their risk is higher, and potentially their tolerance of further therapy is also higher for that reason.
Okay, thank you.
Any other questions? Yes.
Here's one.
Do you have the data about the MPR, the subgroup analysis of the MPR?
Yeah, that's a good point, Dr. Zhang. We haven't looked at that as yet, but that would be something I would be interested in looking at as well, because so the MPR group is higher, as we saw in NeoCOAST-2, so it's a larger group of patients. It would be nice to know if those patients derive benefit or not, if they do not have an MPR, but not currently available.
One more question.
Thank you. Great presentation. In terms of timeline for initiation of the study, was this, after the 816 or at the same time as 816? Could this have been, potentially a randomized study looking at perioperative versus pre? That's one. And then the use of ctDNA, I know you have that as, that was collected in both the studies. Do you have data on that?
Yeah, so to your first point, the CheckMate 816 study read out in 2022. The CheckMate 77T actually just reported in the last 6 months. So there are randomized studies planned, or some may be underway at this point, teasing out various of these variables, dividing patients into PCR versus no PCR, and then randomizing them to further therapy or no further therapy. It'll probably take at least 3 to 5 years for those to read out, which I think will be the gold standard eventually. So on the viewpoint of ctDNA, we do have ctDNA data from CheckMate 816, which we've published, and there was a question at the main session where Dr. Casconi responded that the 77T ctDNA data is being presented soon. So I think that's a good point. It would be interesting to try and integrate those data into this analysis and see if you can further refine those patients, at least in an exploratory fashion, who benefit from adjuvant therapy or not.
I have one final question. I think the most surprising thing to me is that the PD-L1 negative patients did better. And do you think that's reflecting that PD-L1 remains an imperfect biomarker and that there's just better biomarkers waiting to be discovered? Or do you think there's a good biological explanation for why that group did better with more immunotherapy?
I think your point is a good one, because the PD-L1, it's important to remember in these studies, both of them, the PD-L1 was done on the initial core biopsy, not on the resection specimen. So that core biopsy is a small snapshot of a large tumor. So it's quite possible that there may be heterogeneity in some of these tumors with PD-L1 positive. The other point I would say is that what's falling out to me is that patients who are at higher risk and PD-L1 negative, by virtue of the fact it doesn't respond as well to neoadjuvant therapy, when they come back to clinic after surgery, they're at higher risk of relapse. So I suspect what we're doing is any further therapy, be it nivolumab, be it further combination immune checkpoint, might push that and deliver benefits. So I think that's what we're seeing, some combination of those two things.
Thank you. Thank you. Our next speaker is Dr. Annette McWilliams from Fiona Stanley Hospital in Perth, Australia. She will present triaging, and it says ILST, but that's the International Lung Screening Trial, participants at program entry, comparing performance of two different systems, the PanCan versus the LungRADS protocol. Dr. Annette McWilliams is a consultant respiratory physician at Fiona Stanley Hospital and clinical associate professor at the University of Western Australia in Perth, Australia. She also holds the role of clinical lead of the Thoracic Tumor Collaborative of Western Australia. She has been an investigator on the Pan-Canadian Early Detection Lung Cancer Study and the International Lung Screening Trial. The focus of her clinical and research work over the last 20 years has been the early detection, diagnosis, staging, and treatment of lung cancer. Thank you, Dr. McWilliams.
Thank you, and thanks for this opportunity. And I think I'm the non-oncologist here today, the only non-oncology treatment. So I'm presenting this work on behalf of, all the investigators, the International Lung Screening Trial investigators, and this is data from 4 countries, Canada, multiple sites in Australia, Hong Kong, and Spain. And this was an International Lung Screening Trial, was a prospective trial, and we enrolled participants who were current or former smokers of tobacco between the ages of 55 to 74 years. And they were eligible for the trial either on the PLCO M2012 risk score of more than or equal to 1.51% or USPSTF 2013 criteria. And we had a total of 4,494 participants that were prospectively enrolled, and we compared the management of the screen-detected lung nodules with a risk-based protocol, the PanCan, based on the PanCan nodule risk calculator, versus a recorded LungRADS version 1.1 score on the baseline CT. So this is how do you work with patients just with one CT? These patients have no prior CT scans for comparison, and how do we manage these patients, these screen patients? So this is the PanCan nodule management protocol, and this is based on the maximum nodule risk score that's been calculated for each patient or some other radiological features. And there's 5 different categories. Category 1 is the very low risk, and these patients are at baseline CT, have no nodules at all, or they have very low risk nodules where the maximum risk score is less than 1.5%. And these patients were triaged to a repeat rescreen CT in 2 years. So that's category 2 was low risk category. The maximum nodule risk score was 1.5 to 6%, and these patients were triaged to an interval CT scan at 12 months. Moderate risk category, category 3, had a risk score of 6 to 30%, and they were triaged to a repeat to an interval CT scan at 3 months. The high risk category, category 4, had a maximum nodule risk score of 30% or greater, and the category 5 had other radiological findings that were suspicious for a primary thoracic malignancy. And these 2 categories required immediate referral for diagnostic workup to a respiratory physician or pulmonologist. Other suspicious findings were things like a large mass that was clearly suspicious for a thoracic malignancy, a pulmonary nodule with any intrathoracic lymphadenopathy, pleural effusion, distal atelectasis, or lobar collapse, or an endobronchial nodule that was segmental or proximal airways, and the radiologist didn't think it was mucus. And those patients require prompt assessment. This is the LungRADS version 2022. It's currently being used in the US for managing screen-detected nodules. We used a slightly earlier version, which had some minor differences, but they're very similar. So what this table shows how patients were triaged on the first CT scan when they entered the program. And this is comparing the PanCan protocol versus the LungRADS, and these are the different risk categories. And what we can see here is that 75% of the screening participants were triaged to the very low risk category and didn't need another CT scan for 2 years. There was equivalent proportions of people in the moderate risk category between both protocols, but with the high risk category, you can see that the PanCan protocol triaged only 2.8% of participants to need immediate referral for workup, compared to the LungRADS protocol, where it was a higher proportion were triaged, 7.4% requiring referral and diagnostic workup. And this difference was highly statistically significant. This is showing all the participants, I've summarised this from my slide this morning, all the participants triaged to each category by PanCan or LungRADS, and all the lung cancers. There was a total of 109 lung cancers participants with lung cancer detected in that 2-year interval between the 2 screening CT scans. And this shows that the very low risk category patients using PanCan had only a 0.3% positive value for lung cancer. So there were some lung cancers in that group, but it was a very low number. When we look at the high risk category, 48% of those participants ended up with a diagnosis of lung cancer using the PanCan protocol. Compared to LungRADS, their high risk category, the positive value was only 18.1%. This difference was highly statistically significant. And compared to PanCan, using the LungRADS protocol, required 2.63 times as many CTs or more CT scans or more positive scans to diagnose the same number of lung cancers. So in summary, the PanCan risk-based approach at single baseline CT with the only scan that you have to use demonstrated improved selection of both low risk and high risk categories. 75% of low risk people would be safely rescreened in 2 years rather than 1 year, with a reduction in resource and costs. And compared to PanCan, the use of LungRADS protocol required 2.63 times as many positive scans to find the same number of lung cancers. And PanCan, the use of the PanCan protocol reduced the number of participants requiring urgent referral for diagnostic workup at their first baseline CT. Thank you.
Take questions from the floor or the computer.
We do have one from the press online. ESCO Post again. The discussant in the presentation did not address the comparison between the two approaches, but it seems PanCan is a better protocol. Would you agree, Dr. McWilliams?
I would. That's why we believe in it. It was one of the secondary outcomes of the International Lung Screen trial. The first outcome was comparing the risk assessment of the participant using the PLCO model, and that was presented in a presidential symposium a few years ago now. And this was the second major hypothesis or aim of the project, which was to compare or prospectively validate the PanCan nodule risk score. Now, we developed this and published this in the New England Journal back in 2013, and it was developed from a very large cohort of screened patients. It was validated in another large screened cohort, and since that time it has been retrospectively validated in multiple screening and clinical cohorts around the world over the last decade. But this was the prospective validation. So this study shows, I think it shows, the work of 20 years, that this shows in a prospective validation of using this risk-based model to manage nodules with only one CT. You don't need another scan, you don't have to do fancy volumetrics, just need one CT with a risk score. And that can help you triage and manage your patients in a more streamlined fashion, reduce unnecessary referrals, reduce unnecessary CT scans. So I think this is the next step. We are moving towards risk-based models with both enrolment of participants for screening as well as management of nodules. will probably replace this one day. We'll wait and see. But I think moving forward, we're going to be using this model in the Australian program, which is commencing next year on the 1st of July 2025. We're incorporating the PanCan risk-based approach for nodule management at baseline. It's currently being utilised in British Columbia, Canada. They are using this in their screening program, and also colleagues in New Zealand who are doing a pilot screening project in the Maori population are using the PanCan risk protocol as well to validate that in the Maori population. So I think it's the way to go. I think it's more efficient. So we're going to be using this going forward, and I think it may need to tweak it, and we will gather more data as we go. But I think it's an advantage using it without having to require fancy software.
I have one last question. Dr. McWilliams, it was very impressive results, and I think it's wonderful to see that we can keep refining our processes, get better and better at screening. You did have 10 lung cancers in the very
Yes.
low risk population, and I was curious what the stage distribution was of those 10 lung cancers that we thought wouldn't have happened.
Yes, most of them were actually, and I looked at them in detail, most of them were incident cancers, so they were not there at baseline. So there were 10 overall, 2 were small cell, there were 8 non-small cell in that group, and the majority, 7 out of the 10, were incident cancers. So they were not there on the original baseline CT. So these are cancers that developed in the interval.
And what stage were they?
There was stage, the first one, there were 3 prevalent scans. The incidence cancers, excluding the small cell, there were 5 non-small cell incident tumours, 3 stage 2s, a stage 3 and a stage 4. Most of those were diagnosed after the 2-year scan. So there is, and the overall, if you look at the incidence rate in that group, it was about 0.2%, and it's the same in the other groups as well, and the same with the lung RADs. So 0.2 incidence rate of cancers it seems to be quite common if you look at the other screening trials. So yes, they are more advanced stage, but would have they been caught earlier? It's hard to know. But it's a small number overall. But there's the interesting there were 3 prevalent cancers. And they were quite interesting to me because they're missed cancers. So there were nodules at the baseline CT, so 3 small nodules that were low risk. One was diagnosed at 9 months, had a clinical CT scan for another reason, and a nodule which was 3 millimetres at baseline was seen to have grown. You are going to get these biologically aggressive tumours like small cell lung cancer. And that patient had surgery, they saw it was abnormal, it was then referred on for workup, it was a stage 1A adenocarcinoma. So that patient was lucky because it was picked up on a clinical scan. The other 2 participants just came for their 2-year scan. So these are prevalence, low risk nodules, very small, and they had stage 3 disease at 2 years. So there were 3 missed prevalence cancers out of 3,380 people. So it is going to happen. I think it's very important to be transparent and honest and look at those. And the incident cancers, you are going to get those as well. But yes, most of those were stage 3, not stage 1 though. There was another stage 2, and this is an important point to bring up. It shows the limitation of CT screening. There was another clinical detected cancer that was a stage 2. It was detected at 17 months. It had a negative, no nodules on the baseline CT. Was due to have a 2-year follow-up scan. That patient presented with clinical symptoms at 17 months and was found to have a central squamous cell carcinoma of the lung. That was a stage 2, and so this was an instant tumour. They went back in detail and looked back at the CT baseline multiple times. So this was an occult central squamous cell cancer. And we know from work I've done in Canada with Stephen Lamb in the British Columbia Cancer Screening Program that we had there, and from the Korean group that presented their data at the World Lung a couple of years ago, that central squamous cancers are invisible on CT. So CT screening does not detect those cancers. So we have seen this before, and it's certainly been seen in other screening programs. So.
Those are probably the only ones who might have been detected by sputum cytology.
Even sputum cytology low, but maybe autofluorescence bronchoscopy. We did that in the Pan-Canadian study. But,
okay, thank you so much.
Yeah.
Thank you. And we'll move on now to our final presentation from Dr. Kaiken Zhou from the Shanghai Pulmonary Hospital, who will present phase 3 study of ivonescimab. No, I'm going to say that wrong. Ivonescimab, AK112 versus pembrolizumab as first-line treatment for PD-L1 positive advanced non-small cell lung cancer. This is an interim analysis of the HARMONY-2 trial. Professor Zhou studied medicine at Nantong Medical College and got a Master of Medicine at Bangbu Medical College and PhD at China Medical University in China. He worked at affiliated hospital of Bengbu Medical College until 1998, and then he moved to Shanghai and got a position as professor and director of the Department of Medical Oncology at Shanghai Pulmonary Hospital, Tongji University. He has more than 30 years of experience in clinical oncology, with his main research interests focusing on early detection, molecular targeted therapy, and immunotherapy in lung cancer. He has led or been involved in many multi-center clinical trials, including Optimal. I'm going to not list all of them, there's a whole bunch. And has published well over 200 articles, including in journals such as Lancet Oncology, Respiratory Medicine, Journal of Clinical Oncology. And he's very involved in several professional societies, including this one. He is editor-in-chief of Translational Lung Cancer Research, associate editor of Lung Cancer, and serves on the editorial board of several major oncology journals. And I'd also be remiss if I didn't mention that he is the president-elect of the IASLC. Welcome, Dr. Zhou.
Yeah, thank you very much for your excellent introduction. I'm quite happy to present our data of the Harmony 2 phase 2 study on ivonescimab versus pembrolizumab as first-line treatment for PD-L1 positive advanced non-small cell lung cancer. So ivonescimab is bispecific antibody targeting PD-1 and VEGF. In preclinical study, we found that this compound has efficacy against PD-1 as well as anti-VEGF efficacy. There is clear synergy in animal models. In our previous phase 2 study, we found that the compound demonstrates promising efficacy and a safety profile as first-line treatment advanced non-small cell lung cancer with positive PD-L1 expression. Harmony 2 is a randomized phase 3 trial was designed to show superiority ivonescimab versus pembrolizumab as first-line treatment advanced non-small cell lung cancer with positive PD-L1 or negative EGFR and ALK. This slide just shows the design of the study. Eligible patients, the 398 patients with advanced stage non-small cell lung cancer and PD-L1 positive expression, but negative EGF and ALK, was stratified by clinical stage, histology, and PD-L1 expression. Then randomized at 1-to-1 ratio to receive ivonescimab 20 milligram per K or pembrolizumab 200 milligram every 3 weeks up to disease progression, intolerable toxicity, or no clinical benefit. The primary of the study is big assess progression-free survival. The second endpoint are usual, just shown in the slides. Baseline characteristics are well balanced between two arms. About 45% patient had squamous non-small cell lung cancer. 42% of patient has PD-1 high, that is PD-L1 TBS, 50% or high expression. 13% patient had NIVO metastasis, and 18% of patient had asymptomatic brain metastasis at baseline. Primary endpoint is shown here. You can see two curves separated from the beginning, favoring the ivonescimab hugely. Median progression-free survival was 11.1 months versus 5.8 months. Hazard ratio 0.51, significant p-value. This slide just shows the progression-free survival in 4 subgroups: PD-1 high, PD-1 low, the squamous, and non-squamous non-small cell lung cancer. This subgroup patient could get comparable clinical benefit in terms of progression-free survival from ivonescimab compared with pembrolizumab. Hazard ratio range from 0.46 to 0.54. Safety profile is here. You can see two compounds were well tolerated. There is a little bit high treatment-related adverse events, serious treatment related adverse events in the ivonescimab arm compared with pembrolizumab arm. But incidence of the discontinuation was quite low in both arms. There was no treatment-related deaths in the ivonescimab arm. This slide just show the most common treatment-related adverse events with the incidence 10% or high. You can see we see proteinuria, AST, ALT increase, and etc. This toxicity, many lab toxicity, has no clinical meaningful. So this is first randomized phase 3 study to demonstrate clinical significant improvement in efficacy with a novel compound compared with pembrolizumab in advanced non-small cell lung cancer. I would say that ivonescimab is novel first-line treatment for patients with advanced non-small cell lung cancer with PD-L1 positive, that is TBS 1% or high, but without positive EGFR and ALK. So I'd like to stop here. Thank you very much. I'd like to take some questions for you.
Any questions for the doctor?
No questions.
I have a question for you. Why do you think this is working so much better than, say, the combination of bevacizumab with a immunotherapy agent, a separately administered drug?
I would say that the compound is very tolerated. You can find that the grade 3 and a series the treatment-related events is quite low in the study. We also found that the compound has no incidence anti-VEGF adverse effect, very tolerated. In animal model, we found there is clear synergy between the PD-1 inhibitor and also anti-VEGF inhibitors. So our compound is very tolerated. We have very good the safety profile, has very good preclinical data to show the synergy between the anti-VEGF and the PD-1. We also have several negative study of the dose. Yes, very important. We have a study to show that VEGFR dose is a key factor affecting the synergy of the study. If we use high dose VEGFR inhibitor, will cause the failure of the study. So because of the high dose of VEGF inhibitor, the patient could not tolerate it. You can get the marginal benefit in terms of progression-free survival, but not overall survival. That's why we can get positive result, because our compound is better tolerated with very good safety profile.
Last question related to that. As a surgeon, what I worry about and hear about with VEGF inhibitors is central squamous tumors having episodes of hemoptysis or significant bleeding. Is there any signals around that?
So actually, we have about 10 patients located in the center type, some tumor invading the major vessels just in the ivonescimab arm. After therapy, there is no huge events, adverse events, such as bleeding and etc. So I would say that the compound is quite tolerated even in the squamous non-small cell lung cancer. In China, we do have some phase 2 study in new adjuvant setting. The study will be reported in this afternoon. I'm not sure, this afternoon. So the phase 2 study demonstrate excellent results. Great.
Okay, thank you so much. Thank you to everyone for participating today.
Dr. Martin? Yvonne?
Oh, sorry. Don't worry about it. That's okay.
Yvonne?
Yes.
Thank you, Yvonne.
I'm the patient voice.
Oh, I'm sorry.
That's okay. Should I introduce myself?
Yes. I'm
Yes,
sorry,
please
I didn't-
do.
I don't
Okay.
think I had any information.
Thank you, Yvonne.
That's okay. My apologies. So thank you so much. My name is Yvonne Diaz, and I am a lung cancer patient. I was diagnosed in August 2021 with ALK-positive lung cancer. And since then, I've been motivated to get involved in patient advocacy. I helped co-found a patient charity in the UK called Oncogene Cancer Research. I'm on the board of a US charity called ALK-Positive Inc., and I'm a member of Lung Cancer Europe. I'm involved in various different research projects, looking at grants and all of that work. So it's a real pleasure to join you today as the patient voice. I have some notes and reactions to the various presentations, and really what an exciting day to react to, because we hit so many different areas this morning. And I wanted to start off with detection, where really it all begins. So Dr. McWilliams, really exciting to see your presentation today and such stellar results, especially given the group that you're looking at, which has poor survival rates in this high-risk group, and often they face so much stigma and so to really in isolation as a result of this. So the idea to get to a diagnosis more quickly, accurately, is really welcome to our community. I also just think what you commented on earlier, should AI be assisting this, is a question that I guess comes to patient minds as we start to think about in detection. AI is a very interesting tool that we can be looking at. I often think about how can we get this to patients more quickly as well. So you're already seeing great results across 4 countries. So how can this be rolled out? And screening often has poor take-up. So it really highlights, if you're really so accurate at identifying these people, getting them into clinic is all the more important. So how can that happen? Are there lessons from other tumors we see in breast cancer in the UK where I live? Patients are sent an appointment, and that gets them in the clinic faster rather than a suggestion of come get screened. So anyway, so I hope to see that move ahead. The other presentations, obviously, we're looking at understanding the cancer a bit more. So in TROP2 and biomarker testing, I feel, so grateful at the advances in biomarker testing, and grateful I was diagnosed in 21 and not earlier when this was lacking. And then seeing work happening in this space is truly important to us, especially when you look at TROP2, looking at subvariants. I think this is really important work, and looking at how do we get to better treatments to patients around this. So I think that's really valuable. I guess one of the questions I would have is, in the real world setting, biomarker testing can still be quite hit or miss. So how are we gonna roll this out more? And this obviously would call for more specialized testing. So how can that happen? How can that get more quickly to patients as well? A few of the presentations, Dr. Ford and Dr. Cascone were looking at cures in the early setting, and obviously that's very exciting for all of us, all of our patient community. Those presentations looked fantastic, and from a patient point of view, I do think in the curative setting, we are often more willing to take on harsher, more challenging treatments with the payoff of a cure. So obviously, when these don't work, it's shattering for the patient and for their families. And it is wonderful to see these new combinations, new agents looking at. So that's really from us and our side. We want researchers continuing to do that work. So from these new combinations, I think patients would be thinking about how soon can I get back to regular life after this kind of a treatment? What are the long-lasting side effects? What do they look like? Do we really understand them at this stage, right? And often patients are crossing the spectrum. For younger patients, you may be concerned about going back to work, raising or even planning a family. Older patients, can they tolerate harsher treatments like this? So these are important concerns for us as well. The other thing about this landscape, when I was reading the abstracts, I was just struck about how complicated it is, right? So how can we truly participate in shared decision-making in these cases. This is where there's a lot of talk about this, but what does that look like now? I think for clinicians, it's difficult enough, right? And looking at the work happening in those two presentations, are there adequate ways of measuring the minimal residual disease? So, and really then stratifying these patients. Do you need the adjuvant therapy as well, right? So do you really need to go in for the whole thing? How can you really segment who needs this additional and the full treatment, and for how long? Are we offering supportive care to patients to manage these very complicated side effects potentially as well? That's another key thing for us. And the fact that we are taking, these are resectable lung cancers, are we using the pathological tissue to identify and to use that to indicate what is happening beyond that in patients, right? Can we analyze that further and get more data to really help inform other treatments in patients in future? Dr. Zhu, very exciting presentation today. So obviously challenging the status quo is very exciting, and looking at the stellar results here is really wonderful from our standpoint. From a patient perspective, it was quite a big study conducted in China, so we'd like to see it, like, would it be the same results in other populations as well? So how, and how can we get this again out to patients to sooner as well? So that's truly exciting. Finally, in my closing, I just want to say really grateful for all the research that's underway here to today's presenters. It's the one thing that brings us so much hope. It gets us up every day and lets us live our best lives. So really grateful for those involved in research, obviously to the patients who are paving the way for those of us who then go through this treatment. For yourself as media, I would also say we really need you here writing up these results, shining a light on lung cancer. So we're really grateful for your work, your interest in all of this. So really just thank you to everyone.
Thank you so much. Thank you.
Yvonne, I have a question for you.
Yes, dear.
What advice would you give associations like ISLC, but also public health authorities, community hospitals, other health associations, NGOs and things like that? What advice would you give them from the patient perspective about how to put lung cancer more on the map as a very serious disease that merits their attention, their funding, and their support at the government level too? What's the message? What's the key from your perspective to all of us?
Oh my God, that is such a big question, and obviously a very important one. And that's really, I think, what all of us as a community have this responsibility. So working together on this problem together, shining a light, again, bringing more media attention. This is why the media, the press conferences you're doing here are really important, and getting it beyond the trades into the mainstream. Lung cancer, there is so much stigma around it, and it doesn't matter how you wound up with lung cancer. We need to treat it. We need to help people with the #1 cancer killer. So it's really about working together, involving patients. From our standpoint, I think the work that ISLAC does here is phenomenal. The way patient advocates are brought into all the discussions at the earliest stage in your own work, and advocating that we need to be involved in the clinical trial design all the way through the end, and then involved in our own care, right? And obviously reading the patient. Not every patient is the same. It's very individual. So just really continuing on this big work here. It's a massive project.
Thank you. That's a great answer.
Can I make a comment there? Yeah, I completely agree, and I think the big point is battling nihilism. Having advocacy from everyone involved. I mean, that's why IRC is so great, because we're also passionate, everyone who works in our patients as well. I still remember as a young researcher 25 years ago going over to do lung cancer research. My colleague to Canada, my colleague said, "Oh, Canada would be really nice, but lung cancer research, that's a waste of time, isn't it?" That was 25 years ago. So, look how far what's happened. So I think battling that nihilism in our governments, in our communities, in our hospitals. I have to fight to get enough equipment to do procedures, because the people in my hospital that provide my bronchoscope say, oh, but everyone's quitting smoking, so you don't need, isn't it all going down and you don't need all that equipment now? You're not understanding. So it's educating everyone and being advocates and pushing and battling that nihilism and misinformation, I think and that's where all of us play such a big role.
I think that's right. All of us are advocates, not just the patients, right?
No, everyone. Yeah.
As a conference chair, I'm just going to give a plug for a session that's coming up on Tuesday morning at the award ceremony. There's a named lectureship, the Clifton Mountain Lectureship, and my good friend and colleague Jeff Yang is going to be presenting some really interesting findings from community outreach efforts, a lot to do with stigmatism and also public perception of lung cancer. So I encourage you to attend and listen to that lecture.
If there are no other questions, we'll conclude this press briefing. Thank you. We'll be in this room tomorrow at 10:05 for another presidential symposium press briefing. Thank you.